Salam alaikum. Dear Chairman, dear colleagues and friends, dear ladies and gentlemen, it's a great honor for me here today to speak to you about digitalization as a tool for successful diabetes prevention. Diabetes prevention is my passion, and digitalization I see as a tool to achieve a better degree of diabetes prevention than we have achieved in the past. About myself, I'm Peter Schwarz, Professor for Prevention and Care of Diabetes at the University of Dresden. And my passion is to think about what do we learn from science, from evidence-based science, and how can we translate this into prevention practice. And the today development of digital tools are a fascinating booster for being able to implement prevention strategies on a national scope, on a regional or community level. The current situation is a challenge. This colleague, the coronavirus, has influenced all our daily belongings. And I don't want to say that coronavirus is making diabetes, but here you see 540 people from Facebook, all the red ones will develop diabetes through their lifetime. You could say this is a disaster, there's so many patients, but there's a lot of hope on this slide, and these are the green ones. The green ones live in the same environment. They do the same things we could say wrong, but they never get diabetes. So the green ones have something in them. It could be genetic, it could be epigenetic, it can be behavior, it can be lifestyle, that even contracting all the risk factors, they don't develop insulin resistance, they don't develop diabetes. So the green ones have this secret answer for successful prevention and successful diabetes management in themselves. Like this, there's a lot of new information, but the most powerful information is simple. And these are these two numbers. And these two numbers, in my eyes, are the true prevention of diabetes. If we would walk 10,000 steps from the age of 22, we would not contract any chronic disease. No diabetes, no hypertension, no metabolic syndrome, no dementia, no depression. This is a very interesting, very cool information, and it's actually getting better. If a diabetes patient walks only 1,000 steps more than he normally does, it lowers the postprandial blood sugar by 1.5 millimole. This is twice as much as 1,000 milligram of metformin are doing. So true diabetology and true diabetes prevention is not in our brain as diabetologists and not in our prescription as diabetologists. It's in the muscle of our patient. If we would be able to activate this muscle. 2,700 steps is what the average German is walking. And if I would ask the other way around, how many hours per day we are inactive, physically inactive, the answer is 23 hours and 40 minutes. This is a disaster. Yeah? We are lazy. We are not active. Changing this would make a significant difference for diabetes prevention. We are physicians and we are scientists. We have to understand pathophysiology. Here you see continuous glucose monitoring in a young woman, high normal A1C. All the green arrows means she's eating something, and the purple line is glucose, and there's nothing. Today we know this is healthy. This is someone very insulin sensitive. So she needs about only 1% of her insulin to regulate blood sugar. Her father looks totally different. It's truly her father. He's actually having a better A1C, but a totally different curve. You see, in the morning it's the same, in the evening, but in between there are this fluctuation. Maybe there is something before he wakes up in the morning. There is maybe this was breakfast, this was lunch. Then it's going down. He's not having any treatment. He was not physically active. It is obvious that from a physiological point, this is totally different. The father is severely insulin resistant. So he needs about 80% of his insulin to regulate blood sugar. And this is the physiological difference between both. This is the person where it would make sense to tackle them, to find them, because this is the latest moment where we can prevent diabetes from developing in addressing this insulin resistance. Difficult is we don't find them. But the logical consequence from this in the future for prevention and care of diabetes is this. We should cut the high and the low peaks of glucose. So even if we have the same A1C, and a person with small fluctuation versus a person with high fluctuation, the one with the high fluctuation will die because of stroke or a heart attack. The one with the low fluctuation maybe even does not need an intensive treatment. So this is something to remember for the future of diabetes prevention and diabetology. Diabetes is a disease with a dysglycemic continuum. And that means every increase in glucose level is going along with a worsening of outcome. Every decrease of glucose is improving the outcome of patient. Here you see about 80 years of a patient. And here at the beginning is the daughter I have shown you. And then continuously insulin is increasing. So the person is getting more and more insulin resistant. The father I have shown you is about here, being severely insulin resistant. Proinsulin is transmitting this on a cellular level. This is transmitted by visceral obesity. And due to the release of free fatty acids out of the visceral fat, the insulin resistance is triggered. So having this glycemic continuum in mind, it tells us the pathophysiology behind diabetes development. Now the hepatic fat is coming into the game, and we see even before the father is so insulin resistant, liver fat is continuously gaining in a short period and then continuously going up. I would say the visceral fat is, for us as diabetes patient, is making us sick. Hepatic fat is something increasing our mortality. Here diabetes starts, and here we diagnose diabetes. So we are coming very, very late if we want to diagnose diabetes. The logical consequence would be to act here, where visceral obesity is increasing, where insulin resistance and proinsulin resistance is increasing, and where the liver fat accumulates. So this two fat compartment, basically the interplay between these two fat compartments, make our patients getting diabetes. This is what we have to tackle. And here are two examples. This is subcutaneous obesity. This is visceral obesity. And here is the visceral fat what is making this individual getting a severe insulin resistant. And this person is actually in a worse shape compared to this one, even if this one contains more fat. So the visceral fat depot and the liver fat is making us sick. And here you see the insulin signal transduction cascade. All the boxes are switched on to transmit the signal of insulin until the GLUT4 receptor is moving to the cell membrane, incorporating glucose. All these red substances are coming from the visceral fat because they are secreted out of the visceral fat. The visceral fat is an endocrine gland secreting more than 630 hormones, and these hormones are making us sick. And this is a common soil for many diseases like diabetes, metabolic syndrome, but also diseases like psoriasis, depression, and dementia. So following the logic, it would mean we should tackle visceral fat and we should tackle liver fat. My question is, if I would be in front of you, how can we get the visceral fat away? And the answer is physical activity. The only way to get visceral fat away, or the most efficient way, is physical activity, physical activity, physical activity. But now, how we can get the liver fat away? And the answer here is fasting. If you fast for 2 weeks without eating any calorie, the liver fat disappears. That means basically a water diet. And after about 3.5 to 4 days, you move into a ketosis. So the body is burning, instead of glucose, ketone bodies. They are very powerful fuel for our brain and the heart, so it's good for them. And the ketone bodies are mobilized out of the fat, and they take the fat they can access the earliest. This is visceral fat and hepatic fat. So fasting for 2 weeks with not eating basically makes the liver fat disappearing. This is the fastest gain of health we can generate for our patient. To show you here, there are patients having no liver fat compared to those with liver fat. An obese person with no liver fat has a much better insulin resistance than a slim person with liver fat. And this shows you the disaster we have to deal with. And tackling this basically can lead to a remission of diabetes, because by accumulating fat in the liver and the pancreas, diabetes and insulin resistance moves forward. By removing the fat out of the liver and the pancreas, beta cell function increases, and this can lead to a remission of diabetes. So fasting for 2 weeks can lead to a remission of diabetes, even if the people had maybe already for 5 or 7 years diabetes. And this, in my eyes, is prevention. There are studies done in the field of prevention. You have heard them several times already. 50 or more % of diabetes can be prevented by using lifestyle or drugs, but the only sustainable is lifestyle. There are 5 core goals for successful prevention. This means a sustainable, healthy lifestyle if you want to adopt to all 5. And if you adopt to all these 5 goals, you will not get diabetes. So it's a very easy message. Physical activity and healthy diet prevents diabetes. And if you have diabetes, fasting can lead to remission of diabetes. So if we look at this study, what they have done, they basically, in the Asian environment, reached reduction in visceral obesity, reduction in insulin resistance and glucose. And in the European and Asian environment, I apologize, it was vice versa. At the end, they achieved the same. So addressing insulin resistance, visceral obesity, and liver fat is a strategy for management and prevention of diabetes. But this means if we want to implement, we have to understand our patients. Again, if I would be in front of you, I would ask you who likes to drink a Coca-Cola. Some may say yes, and I would ask who likes to drink a Diet Coke. Maybe some more will raise their hand, and I would say, stop this. Why? Here you see 380,000 patient years on this slide, and it shows you if you drink 1 soft drink per day for 1 year, what it does with diabetes risk. If you drink water, there's nothing. If you drink soft drinks, there's 40% gain. Like Coca-Cola, 40% gain in diabetes risk per year. But if you drink a Diet Coke or Cola Zero, it's 60%. How can this be that the Coke without sugar makes more diabetes than the Coke with sugar? And the answer are the artificial sweetener. By consuming a certain amount of artificial sweetener every day, it influences your microbiome. So it changes the bacteria in your gut. And imagine you are physically active, you drink a lot of artificial sweetener or eat a lot of artificial sweetener. This changes your microbiome. This change in microbiome will produce fatty acids. So the changed bacteria, the bacteria produce fatty acids, and we incorporate them into our body through the gut like any other fat from the food. But the bad thing is these fatty acids are accumulated in the liver and make liver fat accumulation. And this finally, in a person who's physically active, leads that he is becoming a non-responder for physical activity. And this is a disaster because the people want to do something healthy, but they gain the absolute opposite. And at the end, they lead to a situation, they may walk 10,000 steps a day, but it works only as 2,000 steps a day. And this is because of the change of microbiome due to artificial sweetener. So this is already a strategy for prevention of diabetes if we would incorporate this. But also, we have to understand our patients better. If we talk about cancer and infection, the patient normally follow what we recommend. If you talk about diabetes and obesity, we as physicians are out of the game to decide about the lifestyle of the patient, and the patient follows his peer group, his family, his colleagues at work. And so their lifestyle is more important for the lifestyle of the patient than our recommendation as physician. And the trigger for changing lifestyle is purely quality of life. So if we adhere to a better lifestyle, or if we want, then we must feel within 1 to 2 days that quality of life improves. And this is a big challenge. And this is a big challenge for prevention of diabetes. But behavior change works. Motivation, action, maintenance are 3 levels of behavior change. Here you see the techniques you can use for guiding patients through a behavior change strategy: motivational interviewing, reflective listening, change talk. There are standard techniques helping the patient to move to a lifestyle change. And this all has led us to develop standards for diabetes prevention from the IMAGE project. And this is a toolkit for the prevention of diabetes, which currently is implemented in 58 states in the world, combined with an education program for diabetes prevention to helping people to communicate diabetes prevention adequately. And this toolkit is a summary of what to take or what to do to implement the diabetes prevention program, but also to execute the program on the right way, summarizing all these points, easily readable, easily to communicate to the patient, to finally, with a positive mission statement, to make a difference by a lifestyle change for prevention. The training program for prevention manager is available in many countries worldwide in different languages, different ethnic environment and religious environment. So this is something easily to take for a national program. And there are also educational programs, many available for diabetes prevention in different languages, aspects you can take and implement, adapt to your environment and to do diabetes prevention like this. But prevention has to address needs if it should be successful. And there's a three-dimensional patient room here, putting together how sick the patient is, how ready the patient is to change lifestyle. These are the three levels I just have introduced. And there are very individual preferences of the patient. So taking the individual need, the individual preferences of the patient into account, when we can call this as an assessment and call it risk stratification and put it together with digital tools the patient is collecting. Because many of our patients are collecting body weight, blood sugar, blood pressure, daily activities, are active in social networks. Putting this information together in a competence toolbox, we can use this again as an assessment. And then we have 100 activities for diabetes prevention written down here. And doing this assessment, bringing this data together, can tell us which of these activities would be successful for this individual. So this is the first step, how digitalization, by using digital tools and doing digital assessments, can help to identify what is the best affinity of the person to an intervention, to a treatment, to a prevention program. So here is an example where digitalization can make our life much easier. But how does digitalization can work in this field? Here you see how our oral anti-diabetic agent lower A1C, but you also see how lifestyle change can lower A1C. At the end of the table, you see how digital intervention until 2010, 15, or until 20 can lower A1C. And look at this column here. As younger the digital tools are, as better they can lower A1C. How can this be? How can an app on the smartphone, because these are the younger digital tools, lower A1C? And the answer is very simple. We are already in the pocket of our patient by using the smartphones. We have never been so close to our patient than being in their pocket. If we now think about how being in the pocket of the patient can be used to track, but to more important, to set right impulses in the right moment for the right patient, to motivate him for better self-management, to motivate him to a lifestyle change, then this lifestyle change can work. So basically can work out of the pocket of the patient. So the A1C reduction we see here is not done by the app. It's done by the app transmitted lifestyle change. And it's basically the column we see here in the beginning. So this, in my eyes, is the power of digitalization. And this is why I say that smart health can be a disruptive innovation in the prevention sector. And I have the chance to coordinate a strategic forum on European level to assess what is needed to build the right digital tools. And there are many, many abilities of apps who can help to motivate, help to track, help to build social networks, communicate with the physician, but also perform prescriptions and so on. There are also challenges about evidence, integration, data safety, but also digital hesitancy of the patient. Not every patient has the same degree of digital literacy. And this is what we have to have in mind if you recommend the use of digital tools or apps. But there are plenty of new app opportunities in treatment, in prevention, in diagnosis, in using social network technology to communicate in the right moment for the right patient, the right impulse to support better self-management and to support a lifestyle change. There are also behavioral models behind digitalization in diabetes prevention, like information, motivation, and helping to assess or helping to use behavioral skills for a sustainable lifestyle change. We have assessed this and looked at 3,500 articles from the last 20 years about the use of digital tools. And the green arrows means that it's significantly improving A1C. And you see the number of studies, and this is only one table out of 5 from this paper. And there are different characteristics about the length, about how to use it, how is the feedback done, in what kind of patient, what is the age group, and so on. And knowing this, it's like a cookbook to build the right digital intervention or the right app for your usage in a prevention program. And as I said, the power is being in the pocket of our patient and being in an environment where basically everyone is using smartphones and is having apps on their smartphones to be used. And I think this is something, it's a very big seed in a fertile soil for us to build clever, sustainable intervention programs for diabetes prevention. So I'm very sure that smart health will be disruptive. And why? Because it's addressing our daily behavior. It's in the middle of our daily behavior. And this daily routine is the secret answer of successful digitally transmitted prevention. In the European level, we have defined how such an app should look like. It should be very user-centric. It should have technical specifications like written down here. It should have clear objectives in what to achieve for diabetes prevention. There must be requirements to get access. So in Germany, we are in an environment where apps are prescribed from the physician for prevention. And we have a reimbursement developing in a European environment. And at the end, I believe there will be a digital ecosystem for diabetes prevention, training the prevention managers and healthcare providers, encourage the uptake within the management processes for our patient, and integrate apps in our treatment specification. If we ask our patients what they want, they give tons of answers, what is important for them, what they would like. And if we now go back to our motivational behavior process, motivation, action, and maintenance, we can associate the answers of our patient to these different levels of motivation. We can associate the answers of our patient to these different levels of morbidity and also to different levels or different aspects of individual preferences. And this is what makes a good app dividing from a not so good app. The good app is very effective in addressing the intuitive need of our patients. At the end, to give you an overview about the situation in Germany, these are 5 diabetes apps for prevention and care in Germany. It's Zanadio, an app helping patients to lose weight. It's Assista. It's a therapy manager using the traffic light function to help the patient to adjust their self-management. Oviva, also an obesity app prescribed from patient. Vitadio, a very clever type 2 diabetes app using artificial intelligence to help the patient to improve their lifestyle. Mebix as another therapy management app for self-management of diabetes patient. Videa Mellitus, a modern disease management program with diabetes education out of the pocket of the patient, out of the smartphone. And Hello Better, it's an app treating depression in diabetes patients. This is the development from the last years in digitalization and diabetes prevention in my home environment. Is this enough? No, of course not. Don't forget 10,000 steps. Walking keeps us healthy. 1,000 steps more lowers the blood sugar twice as much as 1,000 milligram metformin. Having a pedometer, here are the old pedometer, will be successful in doing this. But don't trust your physician. Here you see 31 physicians in Germany on the slide. Only one is using the stairs. All the others are using the escalator. Airport in Doha, airport in Munich, and airport in Dammam in Saudi Arabia. So these are we as example for our patients. So it would be important that we go ahead, that we walk 10,000 steps a day and convince our patient to follow us, because 10,000 steps keeps us healthy. And don't forget this number. Let's work together with our intuition, with our passion, with our motivation in the field to finally be able to walk away from diabetes. Shukran, shukriya. Thank you very much for your attention. It was a great honor to be here today. Thank you very much.